Good afternoon, everyone, and good morning to those who are joining us from the West Coast. Thank you for attending today's webinar, Regulatory Compliance, the New Paradigm Under COVID-19, presented by Todd McDonough, the Principal and CEO of Healthcare Compliance Network. Please be aware that there will be a question and answer portion at the end of today's webinar. To avoid an influx of duplicate questions, please jot down your questions and wait till the Q&A portion to submit them, as your question may be answered throughout the webinar. They may be submitted in the question box located on the right of your screen, and they will be answered in the order received. Additionally, a copy of the presentation slides will be emailed to all participants following the completion of today's webinar, as well as a recorded version will be available on the website for members only. Again, we would like to thank you all for attending, and I will now turn things over to Todd.
Good afternoon and good morning. Thanks, Bria, for the introduction. I appreciate the opportunity to have the talk with you folks today. As we all have sort of been put into the various remote locations that we are, whether it's at home or secluded somewhere separated within the practice or trying to practice whatever social distancing necessary, we've obviously are understanding that the world that we live in is clearly a bit different than it was several weeks back. I believe wholeheartedly that we will get through this. I'm somebody that believes that those individuals who are working hard from the government side, gathering the data and information that's necessary to understand the distribution, the testing, the elements around building vaccinations for this particular COVID-19 are working tirelessly around the clock to try to take care of this issue. Just a few things, and one of the things early on that we understood in regards to the information that was coming out about COVID-19 or coronavirus, whatever it may be sort of referring to in your world. But the CDC has been that staple of information, constantly putting out updates and information to the extent of how physicians should be reacting to this, how individuals who are in nursing homes may be reacting to this, the information that's necessary in terms of trying to make decisions around treatment, what you should be doing to try to stop the spread. So I just wanted to put a couple of things down here on this first slide that were referenced from the CDC. Obviously, this particular virus knows no boundaries. It is relentless. It moves quickly. And for those of you who may have individuals in your world who don't think that this is a legitimate situation to sort of take some serious natures about, rest assured, hopefully, as the information that's been coming out via through the news or whatever channel that you're sort of taking that from is giving you the understanding of the serious nature of this. People are at risk, and consistently through this process, the CDC has put this at a low. And although all of us at some point or other has heard varying stories of individuals who were healthy, that they may have succumbed to the actual COVID, the nature of COVID is still really starting affecting those individuals who are immunosuppressed or may have some underlying elements in their health, diabetes, potentially obesity, and certainly those individuals who are older. But for all purposes at this point, the CDC is considering the immediate risk to be low. We've all sort of understood the nature of quarantine and social distancing information that'll obviously become standard for what we do and what we have going forward here. And then obviously those signs and symptoms that people should be aware of. Fever and a cough, shortness of breath. Obviously, as organizers and individuals who are treating the population out there, you're getting that information out to not only your patients, but also to your employees as well. Many of you have taken circumstances very well in terms of being able to keep your practices open. Others of you have decided the nature of this was too much and may have shuttered your practices for a period of time. So what we wanted to go through today is just an understanding of some of the changes that have occurred. I had the opportunity over the past weekend to get in and try to get some understanding to the extent of historically what may be out there that we've gone through in our history that may provide us some additional guidance to where this may end up when it's all said and done. Found this interesting graph here, which will depict most of the various SARS and MERS and Ebola, all those elements that have kind of been standard practice for what we are been combating over the the 20th century and into the 21st century. And you can see here by the pink space that somewhere in there is where the point will rest in terms of its the nature of this being the contagious and as well as the level of fatalities that this will take. As I had said over the weekend, I was looking at the Spanish flu, and that was really probably the most referenceable element that had to go in from an epidemiology perspective as it relates to what we're dealing with. Many different circumstances, obviously back then in 1918, there was a circumstance of major significance in that we were going through World War I. And at that time, many of the nursing folks had already been mobilized and pushed over into the European theater. And because of the troop transport and all the information that was going on and transportation that was going on, there was a fairly rapid spread as well. But interesting, just a parallel here. So we've seen a cascading amount of information coming from all of the agencies. And what I wanted to go through with you today was those elements that sort of are relevant towards the physician practice space. So we are responsible for maintaining the health of our patients, but under the OSHA guidelines, we are maintaining that for our employees as well. This certainly has had a level of hand-wringing in that we do because typically we are most worried about our patients. But then now we know that the nature of this is something that we're telling our people that are working for us that if they're feeling not well, not to come in, that there's the possibility of going remote, that there's opportunities and practices that are all sort of taking those extent. The Office of Civil Rights is the main adjudicator of all things HIPAA. The Office of Inspector General in the Department of Health and Human Services maintains oversight over those things that are functional to fraud, waste, and abuse, and covering to making sure that the nature of how practices go about their billing. And there's features there that they've done a little bit for. Obviously, the Center for Medicare and Medicaid have been very much involved in sort of putting some different guidelines out that are helping the practices move through this. And one of the biggest thing, obviously, is moving towards to the telecommunication element. So let's start with HIPAA and some of the things that have evolved with regards to the communications that have come out of HIPAA. HIPAA, perhaps maybe to most people's feelings, is more of an aggravation than it is potentially a way of being helpful. But what's always been important to the folks at the OCR is that they never wanted to stand in the way of the ability for practices to be able to take care of their patients. Thus is the reason why there was exceptions around treatment and payment and operations. The communications that have come around with regards to emergency communications that are relating to the distribution of information to those individuals that could use that information in ways of being able to help understand the spread, help understand those things that are going to be vitally important as we continue to evolve and understand how those individuals who have actually gotten through this are being able to get themselves into a good place, and then obviously hopefully getting to a point where we can flatten out that curve. Everybody has sort of heard that notion ad nauseum, and a lot of that comes with being able to break down not necessarily all of the elements that are related to privacy rules, because certainly there's elements here that still need to be maintained, and the communications is more about who can we give information to, authorizations, without necessarily having to get the patient's authorization, so that there's a even flow of information. That information can flow to those various individuals and associations. Obviously, covered entities, which all of you are, they fall under that description. Physician practices certainly fall that treatment. If there's a way for you to be able to treat without under the privacy rules, without patient authorization, to protect health information about the patient, is necessary to treat the patient or to treat the different patients. So treatment is one of those things that you continue to push for. The bigger things that come with the emergency communication come with the public health activities. It's important that that you recognize that there's legitimate need for the public health authorities and other responsible to ensure public health, that they get access to PHI, and they can able to carry out that distribution of information to get to their mission of understanding more about this particular virus. So public health authorities who may be seeking that information from you, they are legitimate organizations that you can give that information to. If there is at the direction of a public health authority that is acting in collaboration, there's an ability for you to be able to provide that information to those individuals as well, without that authorization. To patients at risk or contracting or spreading the disease, and it authorizes the covered entity to notify such persons to necessary to prevent and control that spread. The disclosure to friends and family and others involved in the individual's care and for notification. The covered entity may share protected information with the patient's family members and relatives, friends, individuals who are responsible for that individual's care. Disclosures to prevent the serious and imminent threat. Healthcare providers may share patient information with anybody as to necessary to prevent or lessen the serious and imminent threat to the health and safety of the persons or the general public. Obviously, these elements are all elements that have certainly come forward with some changes as it relates to the day-to-day that we were going through, and has the OCR mobilizing to make sure that there's the free flow of information is there, so that there's a better understanding across all organizations to try to understand what's going on. The other important aspect that goes to the extent of emergency communications is the disclosure to media and others involved in the care of patients' notification. So if media is seeking information from you, you have to be very careful in terms of that information. You still are under the authorizations that if unless there's been something that has been provided to you, that there is the importance of you of maintaining that. In this age where there may be inbound information from your local paper or from a local radio station trying to gather data, or trying to be able to disseminate whatever information that they feel is important to their audience, you still need to maintain the threshold of authorization to the extent of that for media. So those were some of the first changes that came out of the OCR in relationship to making sure that there was a free flow of information. The next piece of information that came out was the notification of enforcement and discretion to the extent of, I'm sorry, before I go there, I wanted to show you that there is a tool that is actually on the HIPAA's website that can break down very quickly the decision tools for you. This is a tool. All these pages have links that will take you to these entities. So if you've got questions as it relates to the disclosure of information, this really is a very good functional tool in order to be able to help you understand how to disseminate information. But as I was saying, just about a week or so ago, the OCR really made what I would say was the most significant change in terms of anything that we've ever seen from the compliance perspective out of the OCR. And it clearly indicates that all of these government agencies need to react in a way to be able to provide you as physician practices the ability to be able to extend your service lines. And what's really significant to the extent of some of the relaxed elements of this particular change is they are letting individuals use popular apps like Apple FaceTime and Facebook Messenger and Google Hangout and Skype to be able to use these functions for the purposes of communicating with that population who is now potentially homebound or has been restricted to be in their home based upon the state's jurisdiction of either sheltering in place or making sure that people are minding the best and most responsible ways of not getting out and spreading this piece. So it really is fascinating from a compliance perspective to see that there has been this activity in place to help this distribution of information and making sure that you as healthcare providers can still interact with your patients and make sure that those individuals who may not necessarily be affected by COVID, who are still dealing with the daily normal day-to-day stuff of flu, colds, and what other elements that may be afflicting them. And just because we've gone into the notion of being in a pandemic doesn't mean that all of the other healthcare issues that have been out there that have been occurring suddenly have gone away. Obviously, those elements have put a lot of additional stress in terms of what we need to do and how we should function. Ideally, in situations where you may have been utilizing different applications, there are applications out there that have a HIPAA compliant element to that. The Skype for Business, UpDocs, VC, Zoom for Healthcare, DoxyMe, and then Google G Suite's Hangouts Meet. Those organizations will still be able to provide you with a business associate agreement. And if you are looking for that, you are diligent in your efforts to make sure that you've got that element buttoned up, all of those entities have somewhere within their administrative area or their forum area information to the extent of a business associate agreement. It's not going to be likely that they're going to take your business associate agreement and sign that. Unfortunately, as a covered entity, your boss in that relationship, but in these particular cases, they've understood that in order for them to be functionally HIPAA compliant and in meeting those thresholds, that they needed to get that business associate agreement to you. I think I need to provide a caveat to all of this information that this is short-term fixes. This is a relaxing of regulatory statute that is letting organizations like yourself use the various functions and applications that are out there to obviously work in an environment that has obviously been turned on its ear as it relates to COVID-19. The whole push towards telehealth has been, from where we had seen it, we've been sort of looking at telehealth through the American Telehealth Association in one of their accrediting bodies. And we are waiting for the physician practice industry to really embrace this. Well, guess what? I think the nature of this has gotten everybody to sort of understand to the extent that this is a really good opportunity to fast forward yourself into a place where you can start to take some of the common technologies that are out there. And there are technologies that are potentially associated with your EHR where you can get yourself into that telemedicine world. But I do want to make sure that at some point down the road, there will be a rollback. So, if you're utilizing some of these other elements like Apple FaceTime or some of the other ones listed here, when this does come to a conclusion and we are sort of moving back to what would be considered normal, which the new normal is going to be quite interesting from our perspective in the healthcare world, you would have to go back to and look at some of those health HIPAA compliant elements. There was additional information about public facing apps, particularly Google, not Google, but not the Facebook Messenger, but Facebook has a real-time chat app, and then there's a company called Twitch and TikTok. Not sure if people are familiar with those, but those are not acceptable systems to be able to use. People have gone back to being able to utilize the telephone as well, which we have gotten some understanding through some information. It hasn't come out definitively, but there is some information that the telephonic types of visits or the conversations that you are having with your patients may also meet the same sort of payment elements that are happening with regards to the telechat, the televideo elements. So but probably 4 or 5 days later, after the emergency communication information had come out from HIPAA, they then came out with their information as it related to law enforcement and first responders, and again, sort of a reemphasis to the public authorities. Again, the privacy rules are not set aside during emergencies, so it's important that when you are in a position to understand the necessity to disclose information, that you have a very good understanding of this. And as you've seen on all of these slides, there is a link down on the bottom. And as Bria had said, all these slides will be available to you. These will take you to the actual websites to show you the language. What we wanted to do here is just provide you some baseline bullet points of those elements that are involved in some of the current changes that are being sort of put out very much in real time from the authorities at the Office of Civil Rights. So we have suddenly gotten ourselves to understand some of the key phrases: social distancing and remote employees, things that were not in our nomenclature several weeks ago, but now have really become part of what we are living and what we may end up sort of having to do for some time here as we evolve through this crisis. And it's really critical from a privacy and security perspective that I go through what I want to talk about in the next several minutes here. You all have relationships with either a managed service provider or an IT vendor, or maybe some of you may even have your own IT resources available to you within your own practices. It is extremely critical that if you haven't taken measures thus far to be in a position to work with those organizations to understand how to get your people into secure remote environments, you may be okay for the short run that we're sort of talking about, as there was this necessity to have to be able to take those individuals that you sat around and said, you know what, these folks don't necessarily need to be here. They can still work with us remotely. and the importance of what they do doesn't need to put them into harm's way potentially in being into practice. There's obviously an element where there's still folks that need to be there. So all of us are going through that exercise of understanding who those folks are, and you create that list, understand what kind of access those people will need into systems. It's not likely that in the case of this, and that you had available PCs that you're ready to be able to give the 3, 4, half a dozen people to go in and have a secure environment. You may have relied on them having to use their personal devices. And obviously that's fraught with all kinds of elements that make an IT individual squirm a little bit, because IT folks, they like certainty. They like the ability to get a PC, and they get their hands on that PC and they can configure it to be acceptable to your network and put all the various tools on there that they need to be able to keep it safe and secure the information that's necessary, whether it's going to be flowing into your EMR or staying within an encrypted environment in folders onto a shared drive, or maybe even onto a shared space on a PC. So I know that there's a lot that needed to be done sort of immediate, but there's a lot of things that you can do backfilling here and working with your IT folks to make sure that those PCs are a little bit more hardened, that perhaps maybe they can work with your employees to encrypt their routers, and maybe even in the cases, equip a VPN so that there's a secure a connection that goes from that PC that your employees are now utilizing at home back into your network. And that the hope is that you're working in a way to share data so that it's going to be encrypted. Look, I understand that the rules of the road changed here, and there was a lot of things that we had to do as an importance of just making sure that we were keeping people safe. And I'm not telling you that you need to do this tomorrow, but you definitely need to work hard in trying to harden these things up. And the need for that comes in the fact that that the black hats, as I call them, have in their worlds, whether they're sitting somewhere in whatever remote country it is, and jumping onto their PC and their jammies and doing the things that they do on a regular basis to go out there on the internet to poke holes in those various elements where they can find PHI and utilize that PHI in a way that they can make money, because there's real money prior to COVID-19 that individuals that were out there, and they made it a practice of being able to pad their pockets through the process of being able to go out there and try to capture data in ways that they can use tools that equip them with the ability to find those potential weaknesses in a network or an open port, or those things that your IT folks work very hard on and being able to sort of put the plugs into. But this has been an absolute treasure trove of information for those individuals to be able to go out and find those vulnerabilities, because now they know that there's opportunities of organizations who are setting up the people within their organizations that need to have access into that vital protected health information. And it's interesting, and I'm jumping ahead a little bit as it relates to the IT stuff, but I was reading about several days ago that there was information that had come through the Office of Homeland Security, which has the jurisdiction over cybersecurity, and there was actually a détente that had been created, and the information that those groups, those known hacker groups that are out there that are had actually said, yeah, you know what, we'll do a timeout here. We understand that this scenario is one that is that's providing a hardship. But then just reading this morning that one of those groups obviously broke ranks with the detente in is doing the stuff that they would do on a normal basis to try to find whatever exposures that they can, and realizing that there's a lot of opportunity out there for them. So work diligently with your IT folks. It's not a time to worry about the potential of what may be billed and elements there, because believe me, when this is all said and done, and information that is now coming back to sort of bring everybody back into the fold, there's going to be exposures here, and things will go back to normal. When that'll occur, hard to know. A lot of what you're going through in terms of getting people out to their remote environments and taking these are going to be those foundational pieces for what's going to be part of your annual practices around security assessment. And a lot of security risk assessment goes to the disaster recovery and the backing up and emergency mode. And so the functions that you've done as organizations and working with your IT groups, at some point when you come up for air out of this, you document that, because this is the new norm. And this is going to be one of those things that it's outside of the sort of normal things that were occurring with practices on a regular basis. Hacking, the malware elements, the phishing exercises, the possibilities of somebody in your practice who was not staying within their lane and looking at information, and all those things that were potentially reportable events. There's still things that need to be done and maintained, but now you've got a new element here. So what you've learned will become the basis of that disaster recovery and how you need to work from an emergency mode perspective, because it's a whole new different scenario. So more on the human side, and I know we're about compliance, but as an organization, we clearly are and want to be empathetic to the nature of these new norms that we're going through, and we're a remote company, so we are challenged with the elements of communicating with our people and trying to make sure that there's a component of what is necessary to help those folks who have gone out into a remote environment and are now sort of saying, okay, what do I do? I used to like that interaction that I would have with my colleagues, and now I don't have that. And there's ultimately tons of different distractions. The kids have been out of school, and there's obviously that element that's being having to be dealt with. There's the balance of kids pulling on you and making sure that you're attending to what's going on with them. At the same time, you still have responsibilities that you're doing. So again, these are new elements that need to be thought of and looked at, because hard to know how much longer we're going to be in this. Hopefully, it's not for much longer, but then again, we have no crystal ball here to understand that. So you need to be sensitive to setting up those types of communications, have the virtual meetings. We do what's called a huddle, where we come together a couple times a week and are in that practice bringing everybody into a conversation to see what's happening. They don't have to last particularly long, but it's very valuable information, gives people the chance to connect with folks just to see where everybody is. And obviously in this time, our colleagues, we want to know what's happening with folks. We don't know who may have contracted, COVID, or if someone had already contracted it, how they're doing. We spend a great deal of our time in those workplaces and working alongside those colleagues who we know every intimate detail of their lives. So you need to be sensitive to these things and provide them, some guidance and provide them some perspective in terms of now working from a remote perspective. So as I had said before, there's blood in the water, and I was certainly pleased when I was reading from the cyber infrastructure, the folks at the CISA, that there was this detente, only to be completely discouraged by the notion of that this morning when they broke ranks, and it sounds as though once one of these entities sort of falls off the wagon, that it's likely that the other entities are going to feel the need to do the same. So the detente is over. More reason to work in conjunction with IT folks. The other pieces that you need to be thinking about in relationship to moving to a telehealth environment is your med mal, your professional liability. Do you have the necessary coverage to be able to provide this new sort of scope of services? So take a little time, talk to your broker. Most med mal practices policies will provide a broad coverage for professional services. Assuming telemedicine activities are consistent with the customary practice of medicine, then they would generally be covered. But as we've learned from some of our partners, that's not necessarily always the case. If you have moved already to the perspective of buying cyber liability, then look at that information. That's a piece that you really want to make sure, especially to understand just where the liability lies. All those elements that we talked about just a few minutes ago in relationship to those individuals who are going to be remote, and potentially there's weaknesses within the network and potential holes because your IT folks are running like crazy to try to plug those. Go back into your cybersecurity and your riders and see what's there. Most med mal practices have some provisions around cyber, but if you haven't taken the information, or you haven't spoken with your broker to the extent of cybersecurity, it is really something that you need to do, and not just because we're in this particular environment, but it's more so the case that it provides you as an organization that added protection, so that you can put your head down on the pillow. The docs can put their head down on the pillow every night to know that you've got that protection in place. It can vary in terms of cost. Several years ago, we worked with our insurance carriers to try to understand what that cost would be. At the latest cost that we've come down to is if you had to report and you had a breach that was not able to determine 100% low probability of compromise, which is the threshold that needs to be met in order for it to be a reportable event, and you had to report and communicate back to your full database of records or medical records, that could be quite costly when you think about the number of records that are there. The costs of legal, the costs of the communication, where you may have to set up some outside third-party resource to do the interactions with the patients, all amounts to about $20 per medical record. So that's a good threshold that we use, that we pass off to our clients. So if you had 100,000 records, then $20 per 100,000 is a good threshold in terms of getting yourself about $2 million in coverage under cyber liability. Don't know what that would cost. Obviously, that's an element that you have to talk through with your brokers. The documentation. We're moving to remote environments. Hopefully those folks that are plugging in from the remote perspective are obviously on the cloud, interacting with their EHR, or being able to tap back into your servers to get that information in there. You have to maintain that documentation. You have to it's business as usual in that. Now you don't necessarily, you know, if you've got it so that you're going along in your day and you just are working fast and furiously because you're trying to understand not only the ability to run your practice at the same time of being able to get people in these remote environments, that this may not happen as fluidly as it does when they're in the practice. But you've got to make sure you're reminding folks that documentation is a critical element, and that shouldn't be unknown to anybody. There are states and there that may require consents. Thus far, we haven't seen anything that has come out. New York, New Jersey, Connecticut requires consents for telehealth with special requirements. So, you know, go back in and look at some of your state requirements. Well, we have probably, as this information is sort of coming down from the feds, the states may go to relax this, but hard to know. So look for that. And I want to share with you a really important resource that's been out there and available for quite some time now. And now that everybody's been forced into this environment of having to learn and understand how telehealth works, the National Consortium of Telehealth Resource Centers is a funded organization by the HHS. And it's broken into 12 different regions with 2 national groups. And it doesn't cost anything to call them and use them as a resource. It was something that was set up as a functional way to help organizations, and in this particular case, physician practices, the understanding of what currently is evolving in their regions. The regions are broken down into various states. If you use that link and go in, there are a treasure trove of information. Use them. It's a great resource. We've been working with them in conjunction with some things that we've been doing and understanding the compliance around telehealth for several years now, and we've just found it to be an excellent resource. One would believe that in this environment that OSHA, you know, is sort of has sort of come from sort of being that mellow, behind the scenes, got to do it, important to employee safety. Physician practices have never really been sort of under the scrutiny of OSHA. Not sure that that's going to change all that dramatically, but there was some misinformation out there that because of COVID-19, that physician practices, medical offices were going to have to maintain an OSHA 300 log. That is not true. The OSHA 300 log for medical offices has been an exempt function for a long time now, and it would take an act of Congress for that to be able to go back to that perspective. As much as OSHA was part and parcel for what we did every day in terms of the standard precautions, it's become that much more important because we've got to protect our people. We've got to make sure in these environments where we hope that the individual who's coming through the door is not, you know, carrying COVID-19, and we've seen practices for the purposes of just providing a reassurance to their patients that they're using masks and that they're using the personal protective equipment. I haven't heard PPE used as much as it's been used in the last weeks in the 20 years that I've been involved with OSHA, and it's just so vitally important now, and as we've sort of come to understand where this has become hard in information and you know, resources to get at. Coming out of this, you know, it's going to transform how you need to look at your overall practice in regards to emergency preparedness. There for a long time has been provisions in place through Medicare for hospitals and nursing homes and surgical centers that they need to have a well-documented, well-orchestrated, and when I say orchestrated, they had to play through, you know, in a community environment, an emergency operating procedure. Not sure how this is going to evolve when we come on the other side of this, but it is clear that there's going to be facets of emergency preparedness that fall within OSHA, that fall within HIPAA, that your organizations are really going to need to have well understood and well in place to battle against these types of scenarios. Look, we don't know enough about COVID to know that as we go to the smoothing out of the curve here, that we get back to some reasonable normalcy, that there may not be something that sort of crops up in the fall or next winter that requires the same diligence. Now, hopefully, we've learned tons. We've learned to isolate. We've learned to be able to consolidate and test in a way that lets us get on top of it. It's going to be some time before we get to a vaccination, and the treatments are all moving forward. So you really need to work towards this emergency preparedness plan and get yourself into a place where this is something that you can go to. It gives you the basis of the guidelines and the plan that you need to be able to roll this out. Again, there's different resources here that you can look at. Other organizations, everybody, as you saw from one of the first slides, everybody's changing their environments here in order to be able to work diligently towards the efforts of helping practices and helping the healthcare community not feel like they're doing things that would potentially bring harm to them, whether it was through some penalty or through some other element that has to occur from these various agencies that are about audits and about compliance. The OIG, they've changed their processes a little bit, that a physician and other practitioners reduce and waive share cost obligations that a beneficiary may owe for telehealth services furnished consistent with then applied coverage and payment rules. So the share costing element has been rolled back. The telehealth services are furnished during a period of time subject to the COVID-19 declaration. So they've got pieces that they're working on in relationship to making sure that organizationally you don't feel like those things that were normal practice where you'd say, oh, we have to do that, because if we don't, it's a possibility of them coming back and auditing us, or if we do our own internal audit, we may have to self-disclose and provide information and give money back. So these things are all rolling back to some extent for the time being during this particular time. The office, the Equal Opportunity Commission, they've had key aspects with respect to employees and inquiries regarding symptoms. They have, these things that may have sort of caused some concerns in terms of EEOC, again, are things that they're looking at and saying, we're relaxing these elements as a functional way of being able to make sure that that people aren't stopping because there's federal regulation that's requiring people to do certain things. So this sort of loosening of all this regulatory requirement has gone to sort of help organizations like yourself, move forward and move through this in a way that that will provide you that confidence that they're not coming after you. And at some level, they're never really coming after you. I mean, if you're a bad actor out there, sure, there's places where you're gonna, you may find yourself in trouble. But for the most part, these agencies are there to be resources. We've come to learn with HIPAA over the years in live audits that they don't want to come down with a hammer. They will if they don't see that your organizations are doing the right thing. But it's not what their mission is. They're a resource. They're an agency that's out there to try to make sure that that information is being maintained and safeguarded in a responsible way. So the caveat to all of this is that it's all at some point going to roll itself back. So all of this lax information and all the loosening of regulatory standards at some point will go back to where it was. Hard to know when that is. the other important waiver here around 1135. I'm not going to get into this too much because I know that last week the MGMA group had one of our colleagues, Nancy Enos, talking through this and also providing some information. There's information that's on the government, on the CMS website. And also in here, we've created our own fact sheet that will help. We want to be a resource for anybody that's dealing with these types of things. We have a deep base of folks within our network, partners, IT partners, insurance partners, law firms that we work with that are resources to us. So if you've got things that are important to you and that you need to be able to sort of respond to, feel free to reach out to it. I've given my email here. I've got my text information. Obviously, the text is my phone, so if you wanted to phone as well. But this is the understatement of the day. It's an interesting time, and I know as practice owners and practice administrators and those individuals who are trying to do the right thing, that in the back of your heads, it's been a bit of been caught a little flat-footed on this, and there's a lot to learn. There's a lot of opportunity. There's a lot of questions. There's still a lot of stuff that's evolving. Although 1135 has sort of evolved in regards to this, to the federal level through CMS. Talk to your private insurers about what they're doing. Medicaid, I do know that I was listening to the other day to something from the folks at Medicaid that they are now following, and not all states, but 23 states have Medicare 1135 waiver. So with that said, we'll leave a couple minutes here. Obviously, if there's more questions that we go over, Bria, hopefully folks have been throwing some things in, try to answer as best as we can in the time that we've got available here.
Great, thank you, Todd. So if anyone has their questions, you may enter them in the question box now. So we'll get started with the first question. It's a coding question, so if you're able to answer it, that would be great. It's from telephone services, getting conflicting info. We see that 99441-443 as telephone services. However, I am now hearing that for telephone only services, we can use 99212-214 with a telephone specific modifier. Is this true? And if so, what is that telephone only modifier?
I'm going to have to defer on that. Use my email to send that question. I will get that out to our auditors. I am not an auditor or a coder, and I would defer to them on our team that would certainly be able to provide you an answer on that.
Sure. Our liability insurance carrier informed us that they will not cover telemedicine.
They may not have a provision based upon whoever their overrider or the insurance company that overwrites them. It depends upon the nature of how big they are. The extent of them not covering that, I would dig in a little bit more to learn why that's the case. If they've got provisions in place to deal with that. I think in the particular place that you are now, don't let that stand in the way from you of pushing on here, because there's a loosened time, and that time is, we're in that window now. But I would say to you, if they don't have the provisions to get that to you, you may want to have your broker start looking for somebody that does, because it in most of the individuals and certainly the insurers, the insurance folks that we work with, there's provisions for that within a rider or some other form that can be put in place.
Thank you. The next question is, can you expand on the definition of e-visits?
Again, probably going to be best handled from one of our auditors or coders. So use the email or text to send that to me, and I can certainly expand on that with their assistance.
Thank you. Have any guidelines been put out on maintaining strict privacy measures as it relates to practicing telehealth in a home workspace, with family members potentially being present in a home workspace setting, et cetera?
Well, these are the new things that are just not written within the regulatory statutes, and no doubt, not only will we as a compliance company, you as physician practices, we'll be looking at the rules of the road, your policies and procedures when you come out of that. I would say that there's nothing that's definitive, and a lot of times there's some things that OCR is relatively slow to react on, and certainly telehealth has been an area where they haven't provided a tremendous amount of guidance, and certainly to the specificity of individuals within a practice now being remote, having to deal with the complications of kids. No way did anybody within their organization ever sort of sit around their planning tables and say, oh, we got to come up with guidance on that. So have your folks continue to do that. You all know that it's the language that's used is reasonable precautions. Reasonable precautions has been stretched a little bit here. So if you've got people who've got family members who may be overhearing information in a teleconference or some type of video chat or whatever communication form is being utilized, it's incidental. It's the same kind of notion that you deal with in the practice with employees. With employees who may be talking to one another about that. You certainly want to be mindful of it. You want to do what you can to best safeguard that, but don't let it stop you from being in a provision for maintaining and providing care. And there's been nothing that's put out to that extent.
Thank you. Do you see Medicare keeping any of the current telemedicine exceptions in place after the emergency is lifted?
The $50,000 question. I can only give you my opinion as somebody who understands what I know about Medicaid and Medicare and other government agencies, is that it's pretty clear that they'll roll back to some extent. I think there's going to be some learning from this that may provide them the ability to sort of take some of these provisions and make them more sort of regular elements going forward, but I don't think that they want to be in a place where when we come out of this that it's going to be the ability for some of these relaxed elements to be in place. I'm encouraged by how quickly they moved. I'm encouraged that there may be some provisions here that will get them over the hump on some of these things that have made it challenge for practices to get involved in telemedicine. But my gut reaction is that they'll come back, they'll do their understanding of that, they're learning from that, and they'll come out and they'll be responsible in bringing some of these things forward. Unfortunately, I would love to say yes, but I just don't think that's going to be the case.
Thank you. And the last question we have here is, if a patient calls from home and doctor provides 10 minutes of care, do we bill office visit and use the patient's home address? Does the doctor have to be in the office during the call?
Again, just so that I don't misspeak on this, I would prefer just to send that question into me, and I'll get our folks on that and get that back to you. Lot moving around with regards to the whole telehealth scenario. I will say that Medicare has been very quick in sort of responding and making sure that they've provided some of the information that they've had. Your private insurers hopefully are following in line, but you're going to need to sort of communicate with them. Find out if Medicaid has fallen into line with regards to your state. But yes, drop that question into me. And again, anybody who has any additional questions or needs some better understanding, please. We're a resource for our clients, and where we earn our stripes is when we can get into these sort of specific conversations with our clients, and we are happy in this period of time to do that for those members who are out there in California, Nevada, across New England, as well as Maryland and New Jersey.
Sure, and we had one more come through. It says, right now in real time, I just found out that I have a patient who was totally asymptomatic for COVID-19 with random in-office testing. I now know his mother and aunt are in serious condition, inpatient. Is there something from a regulatory status I need to do? And they said, they added, specifically in my personal office where I saw this patient physically 48 hours ago.
Yeah, clearly in environments where there's individuals who are going to be in your work environments, the testing elements here are so challenging because to the extent of how some of these have rolled out, they've been relatively inconsistent. Much of the push that's coming out of the CDC is that if you're experiencing signs and symptoms, to make sure that you communicate with your doctor. That call is going to have to be a really general business call. To how much you're at some level as healthcare providers, you're always sort of exposed to that. And those individuals, you do your backtrack, understand, what and who was has been in contact with them, communicate with those individuals if they're not at work or where they meet, so you want to get that word out to them. If you've been diligent in your processes of maintaining, the good use of PPE, you've increased your internal surface disinfectant, utilizing an EPA standard spray, maybe going through the practice on a much more diligent basis, once or twice a day, doing the hand washing necessary, making sure that people have access to the hand sanitizers. I don't want to say that the exposure is there, but you've done all the things necessary that's been asked from the CDC to try to minimize that. But it's, a lot of communication, work with your internal folks that may, look, we don't know how people will react to that. In healthcare, people have a little thicker skin just by the nature of what we do and on a daily basis, especially within sort of the acute care environments. We work with our patients to make sure that they get what's ever necessary. But this has sort of put a different spin, and it's got a different feel to it. So be sensitive to what individuals may say. You may not know. Someone will say, "Well, I need to stop working for the time," and let them be home and self-quarantine. And so but if the practices of what you've done from a standard precaution level, that certainly is going to have a lesser. It's going to minimize that possibility of transference. Not to say that it's going to be the end-all be-all, but it's certainly, if your group's been diligent about maintaining some of those things, hopefully, it will have borne well in terms of not sort of letting the transmission of that continue to sort of evolve.
Okay, great. Thank you so much, Todd, for your presentation. We're going to wrap things up today as we are out of time. We do have some requests, Todd, that when you receive questions from some attendees that you loop us in on the answers. So if you could just CC me on those emails, I'd be happy to distribute them to the rest of the attendees. So that way they can see the answers to those questions.
Absolutely.
Okay, so once again, the presentation slides will be emailed to all participants and will be available on our website, as well as a quick survey will be coming your way as your feedback is important to us. If anyone has any additional questions, please reach out to the presenter directly. Thank you everyone for attending. I hope you all have a great rest of your day.
Thank you all and be safe.